If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today, we will go through the new NICE guideline on acute asthma, or NG 244, focusing on what is relevant in primary care only. Just like in chronic asthma, the NICE guideline on acute asthma is a joint effort by NICE, BTS and SIGN. A link to it is in the episode description. In this episode, we will just focus on the treatment of acute asthma in children. In the last 3 episodes, we have covered the initial assessment in adults and children and the treatment in adults. And in the next episode, we will cover lessons from asthma deaths. So stay tuned for that. Right, let's jump into it. When managing acute asthma in children, it helps to follow a structured approach to ensure effective and timely treatment. And let's start by looking at the various therapeutic interventions, starting with oxygen. For children with life-threatening asthma or oxygen saturation levels below 94%, we should immediately administer high-flow oxygen using a tight-fitting face mask or nasal cannula to maintain saturations between 94 and 98%. The next step is inhaled short beta-2 agonists. They are the first-line treatment for acute asthma in children. We need to bear in mind that when children require short-acting beta-2 agonists more frequently than every 4 hours, we should discontinue any long-acting beta-2 agonists. For mild to moderate asthma, a pressurized MDI or metered-dose inhaler with a spacer is the preferred delivery method. We will need to adjust the dose based on the severity and response, administering 1 puff every 30 to 60 seconds for up to a maximum of 10 puffs. Children under 3 will often require a face mask attached to the spacer for effective drug delivery. The inhaler should be actuated into the spacer 1 puff at a time, with the child inhaling immediately through tidal breathing for 5 breaths. Frequent beta-2 agonist doses are safe in acute asthma, though children with milder symptoms benefit from lower doses. So, for milder types, 2 to 4 puffs of salbutamol 100 micrograms via MDI and spacer may be sufficient, while more severe attacks may require up to 10 puffs. Bronchodilators should provide symptom relief for 3 to 4 hours. If symptoms return sooner, a further or larger dose up to 10 puffs should be administered, and parents or carers should seek urgent medical advice. Equally, if the child at home does not improve after 10 puffs of salbutamol via MDI and spacer, parents or carers should also seek urgent medical advice. While waiting for help, additional bronchodilator dose can be given if symptoms are severe. Healthcare professionals attending to children with acute asthma in these situations should administer nebulized salbutamol, ideally using an oxygen-driven nebulizer, and transfer the child to the emergency department as soon as possible, particularly in cases of acute severe or life-threatening asthma. In children aged 2 years and older, we should monitor the response to beta-2 agonists through repeat clinical observations and oxygen saturation measurements. Children receiving a beta-2 agonist via a spacer are less likely to have tachycardia and hypoxia than when the same drug is given by a nebulizer. For children under 2 who show a poor initial response to beta-2 agonists, despite proper administration technique, we need to consider alternative diagnoses and treatment options. Children with severe or life-threatening asthma, for example, when the saturation of oxygen is below 92%, should receive frequent doses of nebulized bronchodilators driven by oxygen while waiting for hospital admission. This involves administering 2.5 to 5 milligrams of salbutamol in the nebulizer. If the initial beta-2 agonist dose has a poor response, we should combine subsequent doses with nebulized ipratropium. Continuous nebulization offers no added benefit over frequent intermittent dosing at the same total hourly dosage. Schools can hold a generic reliever inhaler which allows them to treat children having acute asthma attack while waiting for medical assistance. This practice is both safe and potentially life-saving. Let's now look at ipratropium. When symptoms do not respond adequately to beta-2 agonists, we should add ipratropium. This involves using 250 micrograms per dose mixed with a nebulized beta-2 agonist solution while we arrange referral to the emergency department. Then we have steroid therapy. We need to introduce oral steroids early in the treatment of acute asthma attacks, and oral prednisolone is the preferred steroid unless the child is unable to tolerate it. Early use of steroids reduces hospital admissions and lowers the risk of relapse. Benefits typically become evident within 3 to 4 hours. In the acute situation, it is often difficult to determine whether a preschool child has asthma or episodic viral wheeze. For preschool children with severe symptoms requiring hospitalization, we should administer oral steroids even if we are unsure whether the cause is asthma or episodic viral wheeze. However, for children with frequent viral-associated wheezing episodes, we should be cautious with multiple courses of oral steroids. We should use the following prednisolone doses based on age: 10 mg for children under 2 years, 20 mg for children aged 2 to 5 years, and 30 to 40 mg for children older than 5 years. For children already on maintenance steroid tablets, we should give 2 mg per kilo of prednisolone up to a maximum of 60 mg. If the child vomits, we should repeat the dose or consider intravenous steroids if oral administration is not feasible. Treatment courses of up to 3 days are usually sufficient, but we should tailor the duration based on the child's recovery. Tapering is not necessary unless the course exceeds 14 days. Oral and intravenous steroids have similar efficacy, so intravenous hydrocortisone should be reserved for children with severe symptoms who cannot tolerate oral medication. Larger steroid doses generally do not provide additional benefit for the majority of children. Next, we have inhaled corticosteroids. And there's currently insufficient evidence to support inhaled corticosteroids as an alternative to add-on treatment to oral steroids in acute asthma. So we should not use inhaled corticosteroids in place of oral steroids during an asthma attack. However, it is good practice for children already on inhaled corticosteroids to continue their regular maintenance dose during the attack while receiving additional treatment. Children with chronic asthma who are not on regular preventative treatment will benefit from starting inhaled corticosteroids as part of their long-term management plan. There's no evidence that increasing the dose of inhaled corticosteroids is effective for acute symptoms, but we should ensure children already on them continue their maintenance dose, adjusting the dose to achieve good asthma control. In respect of antibiotics, we should not routinely prescribe them for children with acute asthma. Most acute asthma attacks are triggered by viral infections, and there's no clear evidence to support the role of antibiotics in this context. And finally, in primary care, starting a leukotriene receptor antagonist, such as oral montelukast, early during a mild asthma attack may reduce symptoms and the need for follow-up consultations. We also need to bear in mind that many children who have recurrent wheezing episodes triggered by viruses do not go on to develop atopic asthma. The need for regular preventive treatment depends on the severity and the frequency of these episodes. Many may not require inhaled corticosteroids. In terms of admission to hospital, we should admit to hospital children who present with acute severe asthma that does not resolve after initial treatment, and those children presenting with life-threatening asthma, defined as a saturation of oxygen below 92%, along with any one of the following features: a silent chest, poor respiratory effort, agitation, confusion, and cyanosis. However, we should also consider a lower threshold for hospital admission if the attack occurs late in the afternoon or at night, the child has had a recent hospital admission for asthma or a previous severe asthma attack, or there are concerns about social circumstances or the family's ability to manage the condition at home. Before discharging a child from hospital after an asthma attack, they need to be stable on inhaled bronchodilators. Peak flow, or FEV1, should be above 75% of their best or predicted value, and oxygen saturation should be greater than 94%. The discharge plan should cover the following key points: diagnosis, inhaler technique, preventive treatment, personal asthma action plan, exposure to smoke, for example, assessing for environmental tobacco smoke or actual smoking in older children, trigger identification, trying to identify the cause of the acute attack and discussing strategies to manage future exposures, follow-up, arranging follow-up appointments within 2 working days, and finally, specialist review, approximately 1 month after admission. So that is it, a review of the treatment of acute asthma in children. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.